Mm-hmm. We're recording. Okay, great. Back to Trish. So she's been in the behavioral health field for over 27 years and has also been an adjunct professor for the last 17 at Drexel University's Master in Family Therapy program. She is truly committed to clinical and operational excellence through program development that support measured-based care and outcomes. We've seen that with promises. Every single one of our sites is so much more focused on outcomes, understanding the quality of care that we're giving to each and every person that comes through our treatment programs. And those practices align with trauma-informed approach to treatment. So Trish has also created the Delaware County's first young offenders treatment program for first-time drug offenders, and as a regular speaker at both national and regional conferences. Like I said, if you're going to be at the West Coast Symposium next week in Palm Springs, go see Trish speak live. And she is also a licensed clinician, marriage and family therapist, and holds her MFT from Drexel University. She's also served as a field reviewer for SAMHSA for the Treatment Improvement Protocol, counseling approaches to promote recovery from problematic substance use and related issues. She is certified in both co-occurring disorders and substance use and is a certified clinical trauma professional. Did I get everything, Trish?
My least favorite part.
I know. You can go to the next slide. Okay, who we are. And if you want to chime in here, feel free. So as you know, Promises, we are nationwide. We have facilities in Texas, Tennessee, Pennsylvania, Massachusetts, Georgia, and Florida. So I know a lot of you here today. I can see that you're from Georgia, from Alabama, North Carolina. That is, you can definitely find Promises if you are in those areas. So our two newest facilities that we're really, really excited about, Promises DFW and Promises Atlanta. Those just opened this year. And, I think that it just goes to show that it promises, like, because we're so dedicated to these evidence-based programs, our treatment outcomes, every facility is going to feel different, but every facility is going to be really dedicated to the extra support that clients may need when they come to see us. We have mental health specific programs and dual diagnosis. So if you have any interest in learning more about these programs, I'm happy to connect you to the right person. And if you have any questions related to just program information in general, I can send you any like details of our brands or anything you're interested in. You can email pbhu@promises.com, or you can email me directly, callie.boyer@promises.com. So during the webinar, so questions or feedback for me are going to go into the chat box. So where you put your state that you're living in right now, that is all information for me. Not that I'm going to use the state that you're from, but any question about technology or CEs, webinar functions, if your sound goes away, you can just let me know in the chat. And the Q&A we're going to save for Trish. So if you have questions regarding the webinar content, we will take a 5-minute break. Trish is going to come back and answer some questions. At the end of the webinar, we'll answer more questions. You'll put those specific things for Trish in the Q&A. So we can just keep those things separate so I don't miss any questions that you're trying to relay to her. And that's it. We can go to the next one. For the CEs, I know you're all here for these free CEs, and we're glad you are. Just so you know, if you miss more than 10 minutes of the training, then you don't qualify for CEs. So a lot of you are already here, and that's perfect. Just stay with us until the end. Make sure as well that you're only using one Zoom account per person. So that doesn't mean that you can't switch devices. You can go from your phone to your computer and back. But if you and your colleague are right now sharing, looking at one computer screen, only the one of you that signed in is going to get CE credit. So make sure that if you both need CE credits, you're on two separate devices. After the training, you'll go to your CE dashboard. So the same email link that you got today for joining us, you'll get another email that says you're now ready to complete your survey. You'll get an email either way if you passed or didn't pass. So you'll go to that email, you go into your dashboard, and that is where you will complete the survey for today. And that really helps us continuing to better these programs and continuing to give you great content. So we really appreciate your feedback whenever you do share that. And then once you complete your survey, you'll immediately receive a certificate on the CEGO website and those will be stored in CEGO. So if you have an account, you should already see that if you've joined us for separate webinars, you get all of those things in one place. They're saved there. And today we're issuing CE credits from NADAC and NBCC. Slides, other resources, the recording, all of those things will go out next week. They'll be put into your attendee dashboard. You'll get an email that says those things are now uploaded and ready for you. And just give me a few days to make sure I collect all of the resources that Trish talks about and anything like that that we can add to your dashboard, but those will be up next week. That's it. Oh, next week or next month, sorry, we're back with Bill Anderson. So a few of you may notice this is a different webinar than what we intended to have for June. So Bill is going to be speaking to us about the pitfalls of overconfidence and healthy humility in therapy. So if you're a therapist, this is going to be a great one for you. If you signed up for our previous June webinar, I will send you all a separate email and I will go ahead and sign you up for the June webinar that's with Bill. If you don't want to attend, just don't attend. So if you've already signed up for June, you're already signed up for June. If you'd like to, I'm going to put a link to sign up in just a few minutes. So come back with next month. Trish was our first guest on our brand new podcast. So we have a new podcast called Mind Amendment. You can find it wherever you listen to podcasts. We already have a second guest that's been on there this month. So Trish, do you want to speak about your experience on Mind Amendment and what this conversation was about?
Sure. So if you all know me, or if anybody knows me, you know that this is not my favorite thing to do, right? I don't love being on his podcast, but Patrick Cluster, who has been involved in alumni services for years and years, shares another opportunity. So he has Rooted in Recovery, which is one of his podcasts that really celebrates alumni and recovery stories. And he created Mind Amendment to really bring in other individuals, experts in the field of substance use and mental health, wellness experts that talk about how do we take care of ourselves, how do we understand what we need to do for ourselves, support ourselves, and how mind, body, spirit are all interrelated in our overall recovery of whatever we are recovering from. So Patrick is delightful. He is the only reason that I agreed. And so it was an honor to be a part of that. And be a part of kind of what he's trying to create as far as messaging and supporting those that are looking for additional support and how to navigate this world.
Thank you. Yeah, I just put the link to our Mind Amendment podcast page in the chat for if y'all want to go listen to that later.
Perfect.
Awesome.
I will say, if you see it, I don't seem quite the same. I'm a lot more reserved and appropriate on the podcast than I am in live version. So you'll notice.
It's a great conversation.
It is a great conversation. Patrick did a really great job of really asking some of the questions that I think a lot of people are asking, and just how to navigate some of the normal experiences that we all have, let alone some of the recovery efforts that many continue to work through. All right.
I'll let you take it away.
I am going to get started. So I'm not going to go over the objectives again. Everybody knows that the objectives are everything that I talk about during the training, so I never go over the objectives. But I do want to kind of just start before we talk about ADHD. So I'm grateful that all of you are here today. I apologize for my voice. I'm not sure what's happening. We did a couple of months ago, we did the first webinar on ADHD, and not surprisingly, this was something that was really well received. I think we are all on the same boat, that we know that there's a lot of impacts for those that we are working with, whether we are in a private practice, whether we are an inpatient, whether we are an outpatient, or whether you love or are someone with ADHD. And so based on kind of popular demand, we worked to create this second webinar. So if you attended the first one, that's terrific. You'll see some things that are a little bit redundant because I'm going to make sure that everybody gets the same information. It's certainly riddled with a lot more information, but if you didn't make the first one, you're going to be okay, and you'll understand kind of the way that we are navigating through this. But if you did, then you heard me say then, ADHD is one of my favorite topics. It is a topic that has been very near and dear to me for years and years and years. And then, as I joked the last time, I have been in this field for a very long time, worked pretty intensively with individuals who had ADHD and trauma, which we'll get to a little bit in a couple of slides. And then brought my life to marrying somebody with it and raising somebody with it. And so when I say, and some of my closest friends also have it. So when I say I genuinely love ADHD, I literally mean I genuinely love ADHD. But because I was a professional before I was a wife and a mom, before I recognized that I was apparently hand selecting those that had ADHD themselves as being some of the closest to me, um, I understood some of the risks associating with ADHD. I understood the reasons that individuals were struggling, and it really helped me in my journey of marrying and raising somebody. And so hopefully as we navigate through this, you'll get a better understanding of your role and the ways that you can understand it and support it, and the way that we can all understand and address it if you are working in the treatment space. So let's just do a basic conversation about ADHD and start talking about what it is. Last time I did not talk about kind of the criteria as much. I didn't really talk about like how we got to these the diagnoses and how do we understand it, but that is a constant question for me. So people have asked me plenty of time, and so I decided that I was going to put this on here. What's the difference between ADD and ADHD, right? Some people are like, I heard that we weren't doing ADHD anymore. I thought it was not, that we only said ADD, right? So all is true. So I figured I would just do one slide that just kind of walks us through the differences so that you're not confused. So if somebody's saying, I don't have ADHD, I have ADD, but I have the hyperactivity part, you're not like, what? So if we look at it, right, the DSM-3 in the 80s, is the first time that this was really identified. So we have had these conversations. ADHD did not start in the 80s, right? We've had aunts and uncles and family members that, 60 years ago had the symptoms of what we would today call ADHD, and they struggle with completing tasks. They dropped out of high school. They struggled with some of these other areas. They seemed very hyper. They were risk takers, but we just called them something, right? And so sometimes as we look at how we are destigmatizing, sometimes we called them lazy. Sometimes I was too young, right? So it wasn't me, but they were called lazy. They were called like they don't care. They don't do. And so in the 80s is when we identified, and again, not me, because I was only a child, but it was identified in this field that this was an official diagnosis. Interestingly enough, hyperactivity was not even considered a frequent symptom, despite that actually being one of the highest risks for an individual is that H. And so they had the two subtypes, which was ADD with hyperactivity and ADD without. So that's what it was called. So when we're getting some of the confusing pieces of like, I thought it was just ADD, it's this kind of continuum of how we've updated the way that we see and understand the symptoms of it. So in the 87s, the DSM-3R was changed to ADHD, recognizing pretty quickly, right, within 7 years, that hyperactivity is a pretty big piece to this. So we better make that a critical piece to the diagnoses. Then in 94, the DSM-4 came in and changed the name to attention deficit hyperactivity disorder. This change indicated that you could have both subtypes, right? So you didn't have to be hyperactive. You could have the inattentive type, but you also could have the hyperactivity. So they changed it. So where it was once ADD, in 94, they changed it to ADHD. That's where some of the confusion seems to sit. And so those three subsets then were ADHD combined typed, ADHD predominantly inattentive, because everybody has a little bit of the hyper, right? And ADHD predominantly hyper and impulsive. That last one is more specifically, so when we start talking about some of these higher risks, we are talking about that hyperactive and impulsive. That's a really critical element. We'll talk about some of the other, subtypes, but that hyperactivity and impulsive, that's one to pay closer attention to. And then by 2023, the DSM-5 came, minimal changes, but it's now called ADHD combined presentation, ADHD dominantly inattentive or predominantly hyperactive impulsive. minor changes. So from 94, very minimal amount of changes. But what did change, and that's why we're hearing. So a lot of people are like, how come we're talking about this with adults a lot more than we used to? When I first started talking about ADHD, it was predominantly talked about for adolescents, young adults, and children. But today there is an understanding, and that was since that 2013, that the DSM takes into account that this can be present in children and adults. So some of these symptoms, and we'll talk about why it looks a little bit different. Because historically we were overlooking the adults and saying like, no, you grow out of it. I mean, I remember being in the field and people saying they'll grow out of it. That's a silly sentence, right? So when we look at the evolution of ADHD, again, while many still use the term ADD, some people are using ADHD, right? We know that it is ADHD, and then you can do the combined type, right? But that's why there's some of the changes. For a child, that hyperactivity is normally what we identify, right? Because they're fidgety, because they're getting out of their seats, because they're trying to, I used to say when I was working, doing private practice and working in outpatient, are you the child that would always break your pencil point? Because they needed to get up. And so they were trying to find ways to not get in trouble. So they would be like jamming their pencil on the table, because then when it broke, they were like, I need to sharpen my pencil. So it looks pretty consistent like that when we start looking at those symptoms. For adults, it looks different, right? So just naturally, our brains continue to develop. And so that limbic system dominant brain, when you're a child, has developed. Your cortex is quite literally online. So the symptoms look different, which is why they were overlooked before. Because adults, they were not acknowledging this, despite it being a consistent risk. And we'll talk a lot about that today. So when it looks like an adult, what we see more of is like somebody that speeds, right? Somebody that might be what we would call like a workaholic, somebody that never lets go, somebody that has is like seeking like thrilling and exciting events. So it changed. So they're not like constantly breaking their pencil point or calling out, and sometimes they are, right? But it just looks a little bit differently for those adults. And so that speeding was a huge one, right? When I would work with adults, they were like, is that why I always want to have a race car, like a speed car, and I'm driving fast on the streets? I'm like, sure, that's why. Right? So that's the difference. So when we are looking at why this is so important, because research is suggesting that about 60% of children will continue to have symptoms in ADHD as adults. As I'm going to suspect, and we saw kind of how things have continued to evolve over the years, I have a suspicion that we're going to see that 60% is going to continue to rise, that we're going to see the adult symptoms. It's just that it's going to look more similar to what we're about to talk to today, that these symptoms are present, but it's not as interfering as a small child that engages in something different. Right. And so the other piece that's critically important is that ADHD is a spectrum disorder. So what does that mean? It means that somebody can have ADHD and be functioning pretty well and not necessarily have the hyperactivity or the impulsivity, that they don't need medication, that they are able to utilize some organizational skills and some executive functioning skills. And then there's somebody that can be pretty severe over here, where you see the impact that it's having on them. So not all ADHD is the same. That was a lesson learned inside of my household, right? My husband has ADHD and my daughter has ADHD, and it is very different. So we'll talk about why it's so important to involve families in that, that if I didn't understand this, right? My husband was like, why is she doing the things that she does? I have ADHD and I don't do that. And I was like, because you don't have the same ADHD as her, right? So now I got two of you. So that becomes really important, so that we're not saying you don't have ADHD because it's not as severe. It's a spectrum disorder. So here are just some fun facts. I'm going to just quickly go through these. No reason for me to spend a lot of time on them, but I do want to kind of highlight it. Males are almost 3 times, I'm going to get to this one in a couple of slides. So males are 3 times more likely to be diagnosed. There's some reasons for that, right? So, but that's something to pay attention to. And as you are working with individuals, pay attention to the symptoms that we start talking about, because women are being overlooked. So do I think 3 times as many men have ADHD than women? No. Do I think that we're paying attention to the symptoms more with the men? Yes. Has research historically been focused in on men? Yes. So I think that has more to do with this. So an estimated of 7 million US children between the ages of 3 and 17, which is roughly when you start the diagnoses, have been diagnosed with it. That's in 2022, right? So 11% of our population. The average diagnosis is 7. The symptoms can start as young as 3. The average diagnosis is 7, typically, because that's when they're entering school and those symptoms start to really manifest because there's too much structure and the child can't manage it. So that's normally why the diagnosis starts at 7, not because it starts to present at 7. ADHD is a childhood disorder. We just talked about over 60% of those that have it as a child are going to continue to have it as an adult. When we're looking at this, about 6% of adults have it, right? So we're looking at about 15.5 million. And then ADHD is 5 to 10 times more common. This is a big one. 5 to 10 times more common among adults with alcohol use disorder than somebody without. And so we will talk about kind of the correlation with substance use and ADHD. And then approximately 25% who go to a treatment center have ADHD. So if you are a treatment center, this would be an interesting piece that if we're saying about 1 out of 4 that come in for alcohol use have ADHD, how many of you are diagnosing it? So here are the signs of adult ADHD. So again, I'm shifting it a little bit. Last time we spoke a little bit more about those adolescents and children's symptoms. I'm going to move it a little bit to the adults because we did do that. If you want to, Callie already said she would send you some of the information. But just keep in mind, the symptoms aren't incredibly different. It's just that it changes and it seems to settle and shift a little bit because of the development of the brain, right? Everybody's brain develops roughly in the late 20s. For somebody with ADHD, we do see a subtle delay in that. Not that they're not smart, because we're going to talk about that. They tend to be incredibly smart. But the development of that cortex is a little bit behind for somebody with ADHD. So the inattentive part, difficulty paying attention. I want, as we go through this, for you to think of somebody that you might be working with, whether you're an outpatient, whether you're a private practice, or whether you're in an inpatient, depending on where you are, is going to determine the level of need for us to really assess this appropriately. Because as we go through some of these symptoms, I want you to think about how would these symptoms impact that individual's recovery from whatever it is that they're recovering from, right? From whatever it is that you're working on, whether it's relational work, whether it's because of their work, whether it's substance use, right? Whether it's depression or anxiety, how would these things impact them? And are we paying attention? So difficulty paying attention, having trouble following instructions at work or completing tasks, poor time management or organizational skills, losing things, the big one, right? The hyperactivity in an adult can look like it's restless, so they're unable to sit for a long period of time, not the disruptiveness of a small child, but more of like they got to go, they got to go, they got to go. So you see more of like the tapping of their feet, tapping of their hands. They might be more excessive in their talking depending on the type, right? So the inattentive type might not be talking excessively, but the hyper and or the impulsivity can, right? So they're always on the go. And then when you look at the impulsivity, it's somebody that kind of says things before they think through it, right? They're like, oh, I shouldn't have said that, right? A thought comes to them and they're like, poof, and they say it right away. And you're like, oh, you probably should have kept that one to yourself, right? That's when we would say there's an inside voice and there's an outside voice. That's a little bit more of a struggle for somebody that has that impulsivity, acting without thinking, interrupting others, which is a part of that, getting impatient in line, impatient in traffic, right? Those kind of things are more indicative to what we see for the adults. Now, as I had mentioned before, 3 times the amount of men are diagnosed with ADHD than women. And so when we think about some of these critical considerations, so what are things that we as providers need to be paying attention to be able to really help somebody that has been diagnosed with ADHD? Because again, keep in mind, historically, we didn't really understand ADHD. And for years, we made it seem like they just needed to suck it up and be better, right? Like you just need to stop acting like that, and not really understanding how this is impacting their brain, which then impacts their ability, right? So I used to say when I would do this with children and go to the schools and talk about ADHD, when we don't appreciate how ADHD impacts behaviors and we expect a child to engage in the same behaviors as a child next to them, it's the equivalency of asking a child that has a visual impairment to read the same way a child who does not. There's no part of us that would expect a child with a visual impairment to read the same book in the same way as the child that does not have a visual impairment. That's what we need to start understanding for ADHD. It doesn't mean that we're not going to have that child learn to read. It doesn't mean that that child's not going to be successful. It doesn't mean that that child is not going to be incredibly brilliant. It means that we have to adjust the way that we are providing them the opportunity to learn, to grow, to continue, because otherwise we're going to impact their confidence, their depression, their anxiety. And that's what we've seen with ADHD. So when we look at this depiction, right, we see that all of a sudden we started recognizing, like, oh my gosh, look at these little boys that have all this ADHD. Like, we have to fix this, right? We're going to really do some work around them. And then you see a little girl over on the side that's drowning because nobody told her that she had ADHD. And so she starts internalizing things, thinking that she's not smart enough, she's not good enough. Why am I doing these things, right? She's going against the social norms of what society expects out of little girls. And so she's drowning. And then you look at historically what we were doing at the bottom, which is at the bottom of the ocean, was the adults with ADHD. Gone. We're not even paying attention to it at all. So this whole webinar is to raise awareness so that we understand how do we navigate these conversations differently to support that, so that we don't have adults that have already drowned underneath the ADHD diagnoses that nobody helped them understand, and that we save those little girls from also drowning. So here's some of the differences in the gender. So when we look at why are we 3 times as many, boys tend to display the externalized symptoms the most that we think of with ADHD, right? So they tend to act out. We see them as impulsive. We see them as hyperactive, right? They have a lack of focus, right? So they engage in some risky or sexualized behaviors. But we've accepted that. And so what happens is that we're a little quicker to be like, oh, that little boy's got ADHD. So while he has to maybe identify that he has ADHD, and maybe if he's upset that he has ADHD, he has to grieve it. And so we have to treat it and all these things. Those little girls that have ADHD who grow up into women who have ADHD, they might have the exact same behaviors, but those are societal norms that aren't expected of girls. So we label them differently. So girls, we often overlook because it's not what we say is typical, right? So we might see them being withdrawn. They seem to have lower levels of anxiety, or they have higher levels of anxiety and low self-esteem. But I'm going to encourage you to think, is that just the case? Or was there a young girl that had symptoms that she then felt ashamed about or embarrassed about because it doesn't fit the norms, because she's not supposed to act like a little boy. She's not supposed to act hyper. She's not supposed to be running around and jumping. And so we shifted the way that we understood it with little girls, and we oftentimes overlooked it. And so you can see verbal aggression. So for little girls, there was a lot more verbal aggression in their relationships. So they might have picked on others. They could pick on their siblings. They might pick on some of their friends, right? Teasing, because that's incredibly stimulating to the brain. These are younger women and children that increase their risk of sexual assault because they don't see the same red flags and dangers because their brain isn't focused in on those details. That they might engage, if they're impulsive and if they are hyper, they might engage in riskier behaviors. But when we see a girl that engages in riskier behaviors, do we label her differently than a boy? Are we perpetuating it, right? And that might be why when we talk about comorbidities, which we will, we see higher rates of young girls having comorbidities of depression and anxiety. And so when we look at that gender gap, right, the bias in diagnoses, the classic traits may or may not show up for women. And when they do, we are still misdiagnosing them. So even when they have it, we're still saying, I think she's just hyper. I think she's just acting out. I think she's whatever the way that we want to describe it, right? So Women are more frequently misdiagnosed with anxiety and depression. And so it becomes important, and we'll talk about it when we get to the end and we talk about medications, because a misdiagnosis, your diagnosis, if I'm treating somebody with ADHD, which I do create interventions that are different than somebody that has depression. That doesn't mean to say that those two things don't happen, but if I keep treating the depression for somebody that actually has ADHD, I can't get rid of the depression because the symptoms of the ADHD that might have been the reason for the depression are still present. So it becomes incredibly important for us to look at that. It becomes incredibly important for us to talk to those that we are working with to hear what is the language that they have been plagued with. How do they feel that they've been perceived as a result of it? So when you look at like promiscuous versus a ladies' man, same behaviors, different identifications of them, right? Different views of the same behavior. And so then it starts to manifest itself differently, right? So when we look at some of those ideas, right, what are some of the other ways we describe women with these symptoms, right? So if you think of somebody that you have currently in your treatment space who might be presenting with some of these symptoms, what do we oftentimes see? How are we labeling her without fully having an understanding? Does she actually have ADHD? So that's the gender gap, right? So when we look at the diagnosis discrepancy, right, we have the boys that we see that this is kind of what we're diagnosing with, and then we have the girls where we pay attention more if they're like daydreaming. We pay attention a little bit more if they seem like they're inattentive. So that individual we might pay more attention to. They're easily distracted, right? Difficulty organizing their time. But it's worth kind of the conversations for both, right? So I'm not negating that we need to continue to support boys and men. What I'm doing on this call is making sure that you are giving equal attention to the women, because the women are oftentimes overlooked and they also have significant consequences as a result of it. And then because it was misdiagnosed and misunderstood and the societal norms say this isn't right, it bumps up their shame because they feel like I shouldn't have acted like that. You're right. Like that seems to be more of boys. And so the interesting piece that we have, and that's why we have to pay attention to both. I'm not saying we need to pay attention to boys or girls more than boys. We have to pay attention to both. Because with boys, where it can happen is that towards their later years of diagnoses, because of all of the symptoms associated with ADHD, we're more likely to diagnose them with oppositional defiant disorder, which leads to conduct disorder. That is a soapbox I am not getting on today because that one is outrageous to me. And for girls, we tend to diagnose them more with anxiety and depression than the ADHD. And again, those are very different ways of being able to treat somebody if we don't have the right diagnosis. So when we have the risk of late or misdiagnosis in women, so when there's a delay, all of those things that I had just mentioned, right? We are going to perpetuate the shame and the stigma that is oftentimes associated for those young women, young girls, that it then increases risks for them as they continue through their journey. So now they're 25, they're 26, they're 45, they're 50, and they're inside treatment carrying around all this shame because they've been labeled their whole lives of like not trying hard enough, being too promiscuous, not caring about their children, not doing all of these labels, which are just associated with behaviors that nobody helped them to understand how to shift. Those are the risks. So if you're working with children, ask the right questions for those young girls. Make sure you're involving the families. And if you're working with older in any other level of care, go back to their histories and ask them if they've ever been diagnosed with ADHD. I can't tell you how many times in my history of working in inpatients that there would be somebody that was giving somebody a run for their money. And I would sit down with them and not even 10 minutes later, I'm like, has anybody ever asked you if you had ADHD? And they're like, well, I mean, when I was a child, but they said that I don't have it. And I'm like, okay, so let's go back to when you were a child. Tell me the symptoms, because we're about to go after those symptoms, because what research continues to show, if you treat the impulsivity and the hyperactivity, most of the other things start to help go away, including addiction. You can do as many relapse prevention plans as you want. You don't treat the impulsivity, you're going to run the risk that that person's going to continue to engage in the behaviors, but they're going to feel more shame because they know that they received treatment and they're like, I don't know why I keep doing this. You're like, because you're impulsive. We got to treat the impulsivity, right? So that's where we have to pay attention. And again, interestingly enough, which is not surprising, research continues to show that females with ADHD are less likely to be prescribed medications. Even some people saying they think it's PMS. I can't think of anything more patronizing and condescending than eliminating somebody's symptoms because you think it's PMS. Does PMS impact an individual's behaviors? Sure, but let's talk about that in the science of how our behaviors are impacted. ADHD doesn't just show up once a month. That's so condescending for us to be having those conversations. So making sure that we are having that, because otherwise it's gaslighting an individual. Sometimes we label them bipolar. Crazy, right? So we're going to continue to have these conversations because at least all of you on this call today will no longer be a part of that and asking all the right questions. So when we look at the comorbidity, approximately 77% with ADHD have at least one comorbid condition. Depression and anxiety are two of the highest ones with it. Substance use, also one of the highest. 42% have at least two, right? So the same ones, right? We oftentimes see those. Where we start seeing the extras is that when we see a little boy that's struggling with his ADHD, we do tend to give him a lot more ODD. Again, a soapbox for a different time, but oftentimes I am going to argue that we see that based on economic status. And so we see some populations get ODD a lot more readily than others, right? Another issue about us and not this individual child that is struggling with the same symptoms. And so we see those correlations. We do see young boys with more ODD, ADHD, conduct disorder, right? So again, when I worked with young men and adolescent boys, I was like, you don't get to keep ODD because they owned it, right? They've been told their whole lives they have ODD. And I was like, do you know what ODD is? And they'd be like, I don't know. I think it's because I'm bad. And I'm like, it just means that somebody thinks, and I have to excuse my language for a second, somebody thinks you're an asshole. That's all it means. So until you're an asshole to me, you don't get to keep that one. We're going to work on the behaviors that you're struggling with. So ODD, right? So we have to just be careful with that because when we're saying somebody's ODD, we are creating pipelines for them to be behavioral concerns. And you say somebody's a conduct disorder, you're basically putting them as a precursor for an antisocial personality. And we have far few antisocial personalities in this country. Diagnosing them is risking their lives into a world of behavioral consequences and incarceration. So be very, very clear on what that means and helping them to identify behaviors, not just labels. Words matter. Anxiety is very common, right? Depression, very, very common. Bipolar, we also see that. Again, I think it's because they're combining some of these things. That doesn't mean to say that we can't have those two things. I'm not negating that. You can have ADHD and depression. You can have bipolar and ADHD. I'm not negating that. But I just think that sometimes we don't do a thorough enough assessment and we don't know what we're treating. PTSD. So this was one that came out years and years ago because I did work in a treatment space where I was assessing little ones, right? So they were under the age of 18, and we were looking at either hospitalizing them, putting them in a partial hospitalization, right? So these were little individuals that were behaviorally acting out in ways that got them in front of me. And what I was finding is that every one of them was coming in with ADHD. And I'm doing my assessment, and I worked really well with a psychiatrist who was phenomenal. She was amazing. And so I would be doing these assessments and saying, how is it possible that all these little ones with all this trauma have ADHD? Something's up. Because I understand what trauma is, and I understood what ADHD was, and there's a difference between them. And so what we were starting to find is that there are overlapping symptoms. And I'm going to keep going back to the importance of that assessment, right? There are overlapping symptoms, but the causes are very different and important for us to know. So hyperarousal. Yes, a child's hyperarousal and cognitive difficulties easily could pass as ADHD symptoms. There's no doubt. If you don't know the signs to look for trauma. So the sign for me is that I was asking these little ones who had all kinds of trauma. They would have been in a foster care system. They had a history of abuse. They had been bullied at school. They had seen community violence, all of these things that would say, this could be trauma and not ADHD. And some of these children who are being taken or put on stimulants, who had trauma and not ADHD, was making them worse, right? So if we understand trauma, right? So we know ADHD is an executive disorder dysfunction. That's really what it is, right? Easy, easy, easy for me to treat. I love it. That's why I love it. When you look at trauma, if you think of how the physiology is impacted, if you are on high alert for danger because your world is not safe, if you have all sorts of stress hormones, cortisol, adrenaline surging through your body, it's going to make it hard for you to sit still, right? You're not going to be able to pay attention to like a English test when you're assessing your environment for safety. Your brain is on heightened alert. And so that's not an executive functioning disorder. That's a limbic system dominant brain that is in the hyperarousal all the time. When we look at like the reliving of traumatic events, kids that are exposed are going to re-experience traumatic events. And so I used to say this again when I was in the school systems, and these are questions you can ask individuals as you're working with them. ADHD is not episodic. You're not going to have a child that has ADHD at school but doesn't have it at home. And you're not going to have a child that has ADHD at home and not at school. It's not episodic. It's chronic. Trauma is episodic. So reliving traumatic events, when all of a sudden you see a child that seems to be acting very differently in an area, an adult that acts differently based on a triggering event, that is trauma. That is not ADHD, because an adult is also going to be chronic, not episodic. When we look at like the negative views of others, so again, if you're having intrusive thoughts about a traumatic event that you've been through, you're not going to feel present in the moment. You're going to have these intrusive thoughts. If you're distracted because you've been through things that are so difficult for your brain to digest, it can look like you're just being distracted. But with kids in trauma, it's a response to a perceived threat, not a lack of executive functioning neurotransmitters that's allowing for you to pay attention. It's not the lack of norepinephrine that's preventing you from staying focused like ADHD. It's your brain is in a perceived threat and in a survival mode. You don't need to pay attention to English if you need to figure out how to survive. So those are some of the shifts that when we look at that, that's kind of the shift. So when you're asking yourself, is this trauma or ADHD? Those are some of the questions that you can ask in that assessment. That differential diagnosis becomes key. Interrupting, excessive talking, running down the hallways, ADHD, all over the place. They're doing it at home. They're doing it on the playground. They're doing it at school, right? They're doing it everywhere. Intrusive and disturbing thoughts, not ADHD. That's trauma. Avoiding things that remind you of an experience, avoiding like, I don't want to go to recess, avoiding, I don't want to do these things, not ADHD. They would actually do it, right? They'd be like, I'm going to do it, right? Just jumping in. Trauma is episodic. ADHD is chronic. And again, for those that are then getting prescribed medications, the way that I would talk about this is that if we say that this child, and that's what we were doing. So for these little munchkins that I was working with that were getting prescribed stimulants, they were becoming more aggressive. They were becoming more dysregulated. And the way that I would describe this to the parents in the schools, imagine the day that you have the most anxiety, right? Whether it's because you have to present somewhere, whether it's because you have to do something, no matter what it is. Imagine the day that you're full of anxiety and now add 15 cups of coffee. Does your anxiety go down? No, it gets worse. That's what we're doing when little children are being prescribed, or adults are being prescribed a stimulant to treat trauma. It is a different part of the brain that is being impacted and increasing their experiences of a stimulant. This isn't that they can't get the chemicals to start to improve. It's that their nervous system is on such high alert that adding a stimulant, that's why most people don't drink coffee on the days that they're really anxious. Ironically enough, when I had to do that Mind Amendment podcast that I was saying, they were like, Trish, can we get you a cup of coffee? And I was like, no. I'm already anxious about having to do this podcast. Coffee will make me worse. That's what's happening to these little children. And then we blame the children. Well, we tried. We gave them their medication. They're just getting worse. So those are important distinctions for us to be looking at. So when we start looking at what else can impact treatment, I'm going to go over some things that a lot of people might not have heard of that are going to impact your treatment. And it's going to be incredibly important for us to start navigating this through, because if nobody understands it and we don't understand the symptoms that can be present for a person, then they don't know how to manage it differently. And again, ADHD is such a high risk for so many comorbidities that it is so critical for us to ask the right questions, right? So Charles Barkley, I am from Philadelphia, and so I almost just quoted a key basketball player from the 76ers, so I apologize. Russell Barkley is actually the ADHD expert who I meant to say, had a quote that I thought was fantastic. ADHD is not a disorder of not knowing what to do. ADHD is a disorder of doing what you know. And so we are shifting the way that we are providing support to our patients and helping them understand how any of these things can impact their lives that put them at risk of some of these other comorbidities, depression, anxiety, and substance use. So what is the impact on the adult life and their risks? So the things that we're going to go through, again, is their mental health. We're going to talk a little bit about their relationships. We're going to talk about how this can impact work. And ultimately, we're going to talk about how this can impact substance use. And when we look at any one of these, I should have put arrows going back and forth, because every single one of them impacts the other, which then exacerbates the way that they are perceiving themselves and the way that they are navigating through their recovery. So here is one that talks about chronic fatigue. So here's an ironic twist. Those with ADHD tend to have a tremendous amount of energy, right? Fantastic energy. I love it. But then the question is, so why are they so tired? And so I oftentimes laugh because, again, in my personal life, right? Married it, raised it. My daughter, the most energy I've ever seen out of a human being, right? She's got crazy energy. She's in the gym for 3 hours. She's an executive director. She's doing all these things. She's moving and shaking. And then at the end, I'm like, do you want to do dinner? She's like, I'm exhausted. I'm like, how are you so tired? Like, how is that possible? It is possible. I don't ask those questions because I actually know better. But a lot of people do ask that question, because then they're like, well, then you don't have ADHD, right? So we're going to minimize and we're going to marginalize the individuals that actually have it, because we're like, you don't have ADHD if you're so tired. But there is a link to why they're so tired. So when we look at it, the additional causes of somebody being so tired is because of the hyperactivity, is because of their hyper focus, because they are taking so much energy to really pay attention to the things that they need to get accomplished and completed, right? Because if they struggle with anxiety or depression, that is also tiring. And so those comorbidities can increase that, because there is a decrease, right? So the last time that we did this, I talked about ADHD being like a dopamine deficiency, right? So that's why somebody needs the higher thrills, because they need that dopamine rush. It just takes more for them to get it. So they need the risk taking and the thrill seeking. And so that dopamine deficiency does make them a little bit more tired. Those imbalances can contribute to low energy levels. And so when I think of like, so how would this impact somebody, right? Like, why would we need to know that as a provider to be able to make sure that we're helping an individual? Because how many of your clients don't show up to evening support groups? How many of your clients, by the end of the day, they're like, I don't feel like doing that anymore. I don't want to go to therapy tonight. I don't want to go to group tonight, because they're tired. And so it's not an excuse. We're not like, okay, I mean, you're tired. We got to do what we got to do. That's a treatment opportunity, right? That's an identification of something that's going on that you're like, this is the reason why you're tired. So I appreciate it, but like, let's figure out how we do this anyway. right? So other reasons that somebody can be tired, in addition to the hyperactivity and the hyperfocus, is that they don't sleep as well, right? We'll talk about that towards the end. They don't have as good of sleep. There's oftentimes insomnia that can be associated with ADHD. The inability to fall asleep can be very impactful for ADHD. So you tend to see individuals that start to take melatonin, that they have a hard time staying asleep once they fall asleep because their brains are just erasing, right? There's so much going on in there. And then certainly the anxiety and depression. And so, a funny story with my daughter, again, as we talk about like the sleep disorders and the sleep impacts. So when she was little, we had her in her crib, right? So she had ADHD. She was little, right? And I knew it, but I was like, we're not going to diagnose it yet, right? She's just a peanut. And so she couldn't fall asleep at night. So we would put her to bed at 7. She didn't fall asleep for like 2 hours. We put her to sleep at 8. She didn't fall asleep for 2 hours. We put her to sleep at 9 because I'm like, what is going on? And so then we took all of her toys out of her bed. We were like, maybe she just needs to play. Like maybe that's why she's not like playing. And so there's too much stimulation in her crib. And so we took all of her toys out of her crib, and she found like a piece of lint in her bed, and she played with that for 2 hours. That's ADHD, right? I'm not overstimulating her. Her brain just needs to unwind. She needs more time to be able to unwind that brain. And so that's an important conversation to have with somebody, because that's going to impact their ability to kind of navigate through this. The indecision is another one. So again, we have a lot of individuals. This is a pain point for me when I work with my own teams, and have historically, is that when somebody says, I don't think that I want to go to aftercare. I don't really feel like it. I mean, maybe I will. I want to have recovery, but then I don't really want to have recovery. And I'm like, okay, so that is a symptom. The indecision, this is where we come in. We're the subject matter experts. So indecision is normal. And so this idea of like, can't you just make up your mind? No. And so here's some interesting pieces. This idea of like ADHD paralysis, and I'm going to talk a little bit more about it. So we know that people with ADHD struggle with procrastination. They struggle with the executive functioning, right? They struggle with like starting task initiations, time management, all those kind of things. And so that executive functioning can tie into this idea of this ADHD paralysis, right? Where they have a freeze mode, where they become overwhelmed. And so when somebody becomes overwhelmed, it then increases, it can increase their anxiety about having to perform. It can increase the thoughts of like, how am I going to get all these things done? And then it shuts down their brain. And so they call it like ADHD paralysis, right? So when people, and so again, if I go back to like my children, my middle daughter, if you were like, you need to work harder because you are not putting a lot of effort into it, it motivated her. If I said that to my daughter that had ADHD, she shut down. She was an amazing athlete. And the second those coaches told her, if you just tried like just that much more, you would be this type, oof, it shut her down. It didn't motivate her. She didn't get better. She got worse. Right. And so people don't pay attention to this idea. And so when we think of like what we do with treatment and all of these tasks that we are requiring them to do, you need to go to your primary care physician. You need to follow up with a psychiatrist. You need to go to your IOP. You need to make sure that you go to your probation officer so you don't get locked up. You need to make sure. And so then we see that they don't follow through, and they're like, they must not have wanted to do this that much, right? Like, I don't know. Like, that's crazy of them. That's what happens. So this is what makes ADHD paralysis distinct from the executive functioning. Though they're both related, when we have problems with our executive functioning, you struggle with the skills that include planning, prioritizing, managing. And in ADHD paralysis mode, you freeze in the face of those tasks when you're feeling overwhelmed. You just don't know how to do it. And so that's incredibly important. So when we see like the lower levels of dopamine, make it more difficult to start that engine. I'm going to hit a couple more slides, and then we're going to take that 5-minute break so you can stretch, get a cup of coffee, whatever you need. And if you have ADHD, just so you can stop paying attention to me. So the types of ADHD paralysis. So when we start to look at this, we have the mental paralysis, right? ADHD kind of mental exhaustion. So mental is when you shut down because you feel overwhelmed. Maybe you're bombarded with too many thoughts. Maybe it's too many emotions. Maybe it's too much stimuli. right? So whatever it is, you just can't organize your thoughts. And you can see that when somebody starts struggling with that. The analysis paralysis, right? So that's the choice paralysis, when you get stuck overthinking a decision. So it can be a big decision. Where am I going to go to college? Should I take this job? Right? Or it can be something small, like I got to call a doctor, right? Do I call this doctor or do I call that doctor? So it can be anything. And then that last one, that task paralysis, can make an appearance if you are faced with a long-term project. I used to say this is when you would throw stuff in the back of your brain closet, right? Like you've got this project and they're like, throw it in the back of the brain closet. And then it becomes so overwhelming that then they get to the night before it's due because they procrastinated because they threw it in the back of their brain closet because they were stunted by it. And then it's overwhelming to them, right? So you get stuck prioritizing the steps, you freeze, and you don't think about the long term, right? All of those things. So this is where when we get to the treatment options, those deliberate skills become so effective to break it down, right? From a child to an adult. If they learn the skills when they're a child, then they utilize them as an adult. But if they've never learned them as a child, our jobs is to help them to learn it as an adult. Having done that plenty of times for the adults, you have to be able to call out, this feels silly. I hear you. I'm about to organize your calendar. Because what's happening is that this paralysis, when you have too many things going on in your brain, it's overwhelming. So it's going to feel like I'm being patronizing to you. It's going to feel like you're like, Trish, I'm a grown ass adult. I don't need you telling me how to do what and when to do it. And I'm like, I hear you. But you didn't learn it when you were younger. And these are skills. It's a privilege to have a skill under your belt. And so you hadn't learned it. And so just bear with me for like 6 weeks. And if you're like, this is still stupid, then we get rid of it. But can we just give it a shot? So you do have to call that out, because otherwise it can feel like you're being dismissive to somebody. And I never want to make a person feel that way. And then motivation. So when we use the motivation, so ADHD, because of the dopamine, is linked to that lack of motivation, right? So here's the life of a procrastinator. Every ADHD person says that they're an amazing procrastinator. Every ADHD person does. And so you see the yo-yos, right? I do really, really well, and then I get bored, and then I plummet. And then I do really, really well because I'm like, oh my God, it's due. And then I perform, right? So you see that. So anytime that you see a yo-yo, you're engaging in essentially like the ADHD behavior. So, and they all claim it works. But the stress that it puts onto them, the difficulty that it causes them, right? All of these other ramifications. And so that idea of the motivation is not about telling them to try harder. You will trigger paralysis, right? Where it slows it down. Motivation is identifying the skills and medication when needed to organize them to be able to do things. The beauty is that when you're at that peak, that's your capabilities, right? Oftentimes it's incredible. It's so high because they're so successful when they are able to apply themselves. But the boredom, right? The executive functioning, when it gets distracted, it drops. And that's where you see Monday, Tuesday, right? Now they're sleeping. Now they're reading a book that doesn't have anything to do with it, right? So they're engaging in all these behaviors. And then on Sunday, they're plowing through, which can get reinforced because it's so stimulating to the brain. So when you feel that a level of stress, it surges adrenaline and cortisol into your brain, which gets you to accomplish those tasks. It's just not good for you, and it's not sustainable. And then I'm going to do one more slide, and then we're going to take a break. But when we take a break, what I'm going to ask you to do is all of the things that I just listed, I want you to put into the chat box. And then any questions that you have, what clinical considerations that we just talked about do you think we're either missing and not asking and addressing? And how do you think it could impact an individual that you're working with? So I'm going to ask you just to put a couple things. I'm not going to be able to read all of them, but just a few of them. And so the last one is anger. Most people don't even talk about anger when it relates to ADHD, right? Because somebody might be trying to cover it and but when we look at it, an estimated 70% or more of individuals report being impatient and quicker to anger. So when we get to relationships, when we get to some of these other things, when we get to the behaviors of our patients inside of our facilities or when we're working with them, pay attention to that one. because ADHD affects the impulse control. So when they get impatient, when they get angry, it's poof, it's a burst. And then they calm down. And then they sit and regret because they were like, I don't know why I acted that quickly. Like, that was terrible of me. I shouldn't have said that, right? So those with ADHD can experience emotions more intensely. I used to say, like, somebody with ADHD was like they were raw. Everything touched them, right? It was so much more sensitive. And so those with ADHD can feel overwhelmed with multitasking, can feel overwhelmed with time management, because these are all things, and when you talk about adults, these are all things that they should know better. So then it's even more frustrating because they should know, like, you can't leave your house at 12 and expect to be somewhere that's an hour and 30 minutes away and stop and get gas and be on time. They're like, I know that. And you're like, okay, so like, then we got a plan. But so it's frustrating to them and it's shameful to them because they're like, I should be bet. Like, I don't know why I'm always late. This is directly related to brain functioning, right? And so then it makes them even more impatient. So they're sitting in a life of like more impatience, which is much more triggering to the anger, right? And so without knowledge of this, it's going to impact their relationships, it's going to impact their work, it's going to impact their life, it can impact their ability to recover. So all of those things. So when I say we're going to take a 5-minute break, it's 11:06 now. We'll come back at 11:11. Think about some things that you think we should be considering when we get into the next phase. So here again, I'm going to pause at this one. We can get to the ADHD at work and in relationships when we get back. So let's take a 5-minute break. Get yourself some coffee. I will read through the Q&A. Thanks. We are ADHD paralysis more specific to hyperactivity combined type versus the predominantly inattentive. I don't think that there's been any research to say that it's more indicative of one versus the other. Somebody with an attentive type can also feel overwhelmed, which is probably when their brain starts to wander off. So I haven't read anything that makes me believe that it's one versus the other. There is another question on selective mutism. That one I don't know enough about. I'm sure it involves anxiety. I don't have anything that makes a correlation between ADHD and mutism. I think that there is then something else that's going on. And so could two things be true? I think it would go back into that. And I'm going to answer one more. How does the anger, impulsivity, and shame for women who have masked possible ADHD experiences all through childhood into adulthood and are now facing Sorry about that. That was my computer. All right, we should be back on track. Callie, everything back to normal.
Yeah, you just made me panic.
Yeah, sorry about that, everybody.
Glad you're here.
I'm back. The unfortunate thing is because I logged back in, your questions are gone. So put them back in the Q&A and I'll get back to them. I apologize for that.
It should still, I'm still seeing them. I can send you, I can just text you the ones that
Okay.
I'm still seeing, but if you see the Q&A at the bottom, it should still be there. But
Okay. It was clear for me now. I see one that's just somebody put in, but if you send them to me, I'll just get back to them to the end. So I apologize for that, everybody. My bad. And sorry, Callie, for giving you a heart attack. I hit the wrong button. All right. So if we start to look at it, ADHD at work. And so when we start looking at how do these things impact an individual and how are we going to perceive treatment so that we don't just treat what we're saying is happening right in front of us, right? We are treating an individual in the context of the system that they're living in. So ADHD impacts a lot of the fundamentals of work and productivity. So paying attention when they're not interested, their memory, right? So is only as good as the attention, organization of items and ideas, tracking time, timeliness, procrastination. So these are all the things that could potentially impact their work. And so we're going to get to in a second that two of the things that are the most impactful, which can have the most ramifications, is work and relationships. So we do want to pay attention to that. We do want to make sure that an individual is able to kind of successfully navigate through that, but it might mean that they need to put some practices in place. So how do you use ADHD as a strength when you're looking at it from work? And again, I'm just briefly going over those because then we're going to start really going into some of the other areas. Time management skills, organizational skills, planning, um, building out your schedule. So even as simple as saying, because we all have it, where is your peak? Where is your energy level the best? Because that's where we're going to start helping somebody to recognize, like, listen, you seem to have your optimal performance at about 11 a.m. That's where you need to do your projects. So do some of your emails in the morning, do some of these things that you find a little bit more tedious that don't require quite the level of creativity, and do the projects when you find that you are peaking. So it's just some of these subtle things that seem obvious, but again, I want to keep saying the same thing. Skills are a privilege. And if somebody didn't learn the skills, then they don't have them. And so this is where we're able to really collaborate with them and start building those skills. ADHD and relationships and the importance of family work. So when we start looking at that, research is going to continue to highlight that couples who have, where there's one or both with ADHD, have the highest divorce rates. So why? Because it's difficult to be married to somebody that you feel is not paying attention. It can be difficult for you to be married to somebody, or it can be difficult for somebody with ADHD to be married to somebody that doesn't have the same energy level. It can be difficult when you feel like they're not taking responsibility serious. If there's angry outbursts, if there's difficulty staying on task, if you aren't keeping a job. So all of these things can impact their relationships and communication, which without support for some individuals with ADHD is difficult. So either they don't have the attention span to have long conversations, or they don't want them, right? And so it becomes too distressing to them. So you try to have a conversation and they elevate, right? Because of the emotional sensitivity and reactivity to it. So when you look at it, um, that's where you see some of the struggles within marriages. And so they are one of the highest rates of divorce. So it's worth having a conversation to be able to identify, like, what's going on in your marriage? How are these? Because these are protective factors. So having a job that's successful, having good relationships in your life where you feel heard and valued and seen, these are protective factors. But if they're not a protective factor, then they're a risk factor. And those same things that could be protective factors are now putting an individual at risk for subsequently substance use, depression, anxiety. And so when you do the family sessions and when you bring them in, right, you can start setting realistic expectations. You can start doing communication. When I worked with teenagers, including my own, if I got a minute of a sentence out to my daughter, that was about as good as I was going to get. Right. So now you got like parents that are trying to have these long conversations with their children. No, you don't have that time. Right. So you better make sure that whatever you say it first, you say it clearly, and then let everything else be a fluff. And so it's shifting the lens so people can appreciate the signs of ADHD. And I know somebody had said with the shame for women, is that possible for men? 100%. Right? Men feel the same levels of shame. It's just for different things. It's just that we're more attentive to men than we were historically to women. But yeah, I mean, we all feel shame. Nobody's has the exception of shame. When you feel that you've done something that hurts people that you love, or you've engaged in a behavior that goes against your values, and you don't understand the reasons why, that's where shame comes from. So that's not gender specific. That's not anything specific. That's just when we start to cross lines that we feel we don't understand why we're doing it. And so shifting that lens in the relationships with others is critically important, because otherwise a family doesn't understand it and they can get mad and they can make you feel bad about the behaviors. And so this, again, funny little story that I had when I worked with a young, he was probably a tween, right? So maybe 14, maybe 13, maybe 12. I don't remember. And so he had very high ADHD. He had been adopted at birth, right? They had a therapist that had told them that he had reactive attachment disorder, which is a whole different soapbox, I'm also not going to get on. And so this family was essentially afraid of their son, right? They were like, he doesn't care about us. He's never going to attach to us. But what he had was really significant ADHD. And so we had done, so the beauty of ADHD, as I said, when you work with just ADHD, it's so quick. It's so rewarding because you start making interventions, they start improving, boop, boop, boop. It's so fast, right? Trauma is so slow. Um, and so he was really progressing, right? Doing well in school. His relationships with his families were improved. All these things were moving. And so, and I kept doing family sessions because it was too important. He They come in on one of the shifts or one of our sessions and they're all really upset and I can see it. And I'm like, uh-oh, what happened? And mom went right back to where she was when we first started, right? Mom has anxiety. Mom was overwhelmed. He doesn't care. This has all been a ruse. He doesn't care about us. He just continues to do the same behaviors. And I was like, hold up, what happened? Here's the ADHD brain. This is the beauty of it. This is what I love about it. So here's a young man that had followed all of the rules. They limited his access to gaming because it was too difficult for him to transition out. He couldn't stop doing it. So his grades were failing. He agreed. So he didn't have gaming except on the weekends. And he was given about 2 hours on the weekends to game. It was the weekend and he went to get on his gaming systems. His parents went out for the day. He went on his gaming system and the computer at that time was needing to um, I don't like refresh, it needed to update. I don't even know exactly. And so his little genius thinking outside of the box brain said, this is going to take too long. It's going to take too much of the time that I'm allotted to be on this computer. So he went into their basement and he rerouted the computer so that all of the energy, I'm not a tech person, went straight to his computer so that it refreshed and it updated in less than 20 minutes. He's still sticking to their rules. He's trying to stay within the 2 hours that he's supposed to have computer, but he found a way to be able to get his computer to update quicker. Genius. Then he got caught, he was playing the game and he got caught up in the moment. He didn't think about it again until his family came home in the evenings and they tried to get on the computer and everybody's was basically shut down. Mom saw that as him not caring about anybody because she couldn't get on the computer because he didn't tell her the truth and it was simply him being a genius, figuring out a way to stay within her rules. And then he forgot. That's ADHD. If I didn't have the family getting the understanding of what this looks like, it would still feel like he had done something. He doesn't care about this family. He doesn't care about anybody but himself. But that wasn't the case, right? This little kid. So when I say, like, it's a funny story because I literally, when I was like, Mom, you're not going to like what I'm about to say. And I'm like, but that is genius. That is genius that he thought of doing that. I don't even know how to say the words right. And he's up in your attic figuring it out to stay in your rules. That's genius. So that's the shift of ADHD. So again, when we think of those clinical considerations, and I know you're putting them in there, one of the most significant that have some of the worst um, outcomes if we don't treat it is substance use. So I'm going to start going through. Some of this was in the last one, so I'm not going to spend quite as much time, but I am going to highlight it for those that weren't in there. But when we look at some of the risks that are associated with it, right, ADHD and substance use, people with ADHD are 3 times more likely to be nicotine dependent. Those with ADHD are 50% more likely to develop a substance use disorder. 1 out of 2. That is one of the highest risks for comorbidity for substance use. And when I say this to people and I say, how many of you have ADHD on your treatment plan? Most people say no. So I am fortunate enough that at Promises, I've created a standardized curriculum that all of our patients have access to that addresses it. So even if our therapists don't put it on their treatment plan, they're dealing with it because it's inside of our curriculum. I'm addressing it. I'm addressing the ADHD, the impulsivity, the emotional dysregulation for all of our patients. But if we're not addressing that, then our patients are going to continue to engage in the impulsivity. So I sneaky bypass some of it, right? By just making sure that we are addressing it, even if we don't put it on the treatment plan. But I'm going to highly encourage everybody, get those on your treatment plan. A recent survey found that more than 15% of adults with the disorder had abused or were dependent on alcohol or drugs. Half of the young adults, so we see a pretty significant impact on young adults as well, right? 69% more likely to have a substance use disorder than compared to their peers that do not have ADHD, right? So you look at some of these risks. How are we not talking about this? It's one of the highest risks for an individual. And most people historically have not been talking about ADHD. I am grateful that recently it seems more people are starting to talk about ADHD. But if we are not talking about this, if we are not addressing it on their treatment plans, if we are not addressing them, if you're in a private practice and you are not addressing some of the ADHD symptoms, if you are in an inpatient, it has to be, because it's too significant and holds too high of a risk. So when we look at, so how do we understand this, right? So what's the difference in the brain activity? The increased experience in the pleasure pathway, right? So when we start looking at like what substance use is in the brain and what ADHD is in the brain, that dopamine deficiency that I had mentioned earlier, that is a critical component to this. So ADHD just produces less of the dopamine, which is where they are engaging in higher risk behaviors to get that same thrill, the same thrill that I can get just from a cupcake, right? So that role of the nucleus accumbens, which is the pleasure reward center, which is in charge of maintaining levels of motivation, there's less of it for ADHD, and it is directly correlated to substance use. And so that idea, so I used to, again, when I was working with adolescents and young adults, when I would have somebody that started into treatment, the three substances that I always saw the most, actually two are probably the predominant: alcohol, marijuana, cocaine, because all three of them really are trying to address ADHD. For adolescents, I saw marijuana and cocaine the most, because they were really trying to manage it. Somebody that says, and if you have the conversation, right, when they're saying, well, I used cocaine, I would have so many young adults and adolescents that were like, I use cocaine, but actually it just makes me feel calm. I'm like, I think you have ADHD, right? Cocaine should not make you feel calm, right? That is, then it is working. It's just not at the level that you're supposed to, right? It has all of these risks and ramifications. So asking the right questions helps you to understand it. And the THC, which is why it's so popular for people with ADHD, is because it quiets the noise, the racing, and it can feel calming. So that's why they like it. So a lot of times kids were like, I use it before I go to bed at night, right? I use it because they're trying to slow down those thought processes. And so again, anytime that you use a substance as a skill, you run the risk of a substance use disorder. So when we talk about why that risk, again, they found that young adults, only 30% of young adults that were using their stimulants, which is a huge risk, and we will get to it, when they were using their stimulants or abusing their stimulants, only 30% were saying that they were using it to get high. Most of them were just trying to feel better. Most of them were trying to clear their heads, right? So we have to make sure that we are not perpetuating a stigma that is not therapeutic. And so that kind of self-medication seems especially common for individuals with ADHD who are undiagnosed. So being able to get that accurate diagnosis, be able to utilize behavioral interventions and medication when appropriate, those are going to be key components. All right, so how does ADHD affect the brain? So I just found that this online, I think it's such a cute way of really kind of highlighting those key areas that both impact substance use and also impact ADHD. So the prefrontal cortex, which we know, right, is what is responsible for our thought processes, manages and controls our high level functioning, such as directing and organizing, and all of our executive functioning tasks. That is impacted by substance use, because when you're using substances, you are less likely to be in your prefrontal cortex. And it is directly tied to ADHD, because there is not enough neurochemicals that are getting into that part of the brain, that dopamine deficiency, that helps somebody to stay focused and attentive. The basal ganglia, which is the neural circuit system, right? So that directs communication within the brain. It's similar to the control tower of an airport. So it is directing how everything should be communicating, heavily involved in like motor coordination, which is typically why those with ADHD tend to be pretty coordinated, really good athletes, as well as habits being formed. So reward and punishment. So when I had said earlier, when you reward your brain by procrastinating and you're like, you got to get this done, and it surges with high levels of adrenaline and cortisol, and then you perform okay, your brain literally rewards that behavior and is like, you just have to wait till the last 10, the last hour before you're supposed to have something due. So it rewards it. So you have to be careful. And so when I worked with parents, I was really careful, and spouses, of like, don't yell at the person to get something done, because otherwise you're about to inadvertently reward it. If I yell for you to get your paper done, to start studying, to do all these things, it's so stimulating. Rewards don't have to be something that you enjoy. It's just what it does to your brain. So if I get your brain really stressed in that space of like, you got to get this done, it's due tomorrow, and that procrastination surges you with some adrenaline and cortisol, then it inadvertently rewards that you just wait. So that's where you hear sometimes people being like, how come you wait until I yell at you? Why can't you just do this on your own? Because it rewarded it, right? That's part of that brain. That when we look at the reticular activating system, that's the network of neurons that aid the hypothalamus, so part of the brain in that limbic system, in regulating behaviors. And so again, I don't need everybody to know all of this, right? But just so that you know, there are neurological impacts to the brain that both impact substance use and ADHD that we need to be paying attention to in order to effectively provide treatment. And then the limbic system, I feel like I talk more about the limbic system than anything else. That is the emotional center of your brain. It's where the pleasure reward center sits. It's where the hypothalamus sits, where there are reinforcing the behaviors at work, right? So everything is inside that limbic system, where individuals predominantly sit in that impulsive behavior. So when we talk about what are some of the executive functions, I'm not necessarily going to spend any time on this one as much because it's talking a lot about what I've already talked about, but it behaves automatically, right? It helps with focusing. That is what the executive functioning. This is what's different than about somebody with trauma, right? Trauma is not a lack of executive functioning. Trauma is a nervous system, reactive system. So it is a fight or flight. ADHD is an executive functioning disorder. It is quite literally the inability to strategize, to motivate, to plan, right? That, or the struggle to, at least. That's very different, right? I would never say that trauma is an executive functioning disorder, but ADHD is. And so when we talk about the medications, we're going to talk about how and where they really target. So the neurotransmitters, so these are going to be incredibly important, also overlap with substance use. So this is why, again, this is what makes this a higher risk for an individual, because it's the same areas that substance use is looking for that ADHD has the deficiencies. So somebody is trying to get to feeling what they would consider like a baseline that feels better, but it's a higher baseline. And so that puts them at a higher risk of substance use. So when we look at some of these neurotransmitter, inattentiveness and distractibility is correlated with lower levels of norepinephrine, right? So those individuals are impacted in their environment. So basically what happens is that everything is very stimulating to them. So when you think of somebody like in an inpatient, how some people are much more reactive to the environments, it can be that that part of their brain is just overactive, right? So something on the desk, we would call that in our house like a squirrel moment, right? Like you were having a conversation and you saw something out of the corner of your eye and you're like, squirrel, right? So those are kind of those moments. The impulsive behaviors found with ADHD are more related to that dopamine in the brain. So when dopamine levels are normal, we repress the urges to do or say something. I might have an urge, that inside voice that I'm like, I'm about to say something. And then because of my dopamine levels, I'm able to repress it, right? And be like, you should not say that, right? This is not a great idea. If I don't have enough dopamine, this is where we see somebody that blurts something out, where they might react, where they might grab something, where they might poke you, right? Those kind of things, those lower levels of dopamine in the brain make impulse control almost impossible without additional support and help, right? So those are some of the things. And then the serotonin, there's lower levels of serotonin. So for substance use, right, somebody is looking for an increased level of serotonin because they just want to be able to sleep, because they just want to feel less aggressive, because they want to have their mood feel better. But that's also lower for somebody with ADHD. And so you're seeing those combinations of like, they're looking for the same things. It's just that as a result of ADHD and the lack of some of these, they require some more things to be able to get them, which puts them at a higher risk for substance use, let alone the impulsivity. So we are now going to get to that last phase of kind of talking about some of the treatments. Some I will spend a little bit more time with than others. But if you have questions about this, then please feel free. I'm going to make sure that I give us a couple of minutes at the end to be able to answer any additional questions. What's going on with this? Well, this was a video. Let me see if I can get to the video. Hold on, I'm going to have to try and get that out. Oh, there we go. It's a simple one for me to figure out. I should have figured that out a little sooner. All right, so assessment and severity. I can't have said the importance of the severity or the assessment enough this entire training. Assessment, assessment, assessment. And so what I always like to say to somebody, including my own family, ADHD will either manage you or you will manage it, but it will not be ignored. So you can try to ignore it, but it's going to show up in your life in one way or another. So ADHD is very manageable, but you have to manage it, right? So I think in the last training I talked about like somebody like a Michael Phelps who has admitted to having ADHD, who when he used that superpower, he became one of the greatest Olympians. He trained, he did all these things. And if everybody remembers, when he stopped training, he started smoking weed. He ended up getting himself in trouble. And then he ended up needing to access care in a treatment facility. So ADHD is going to either be managed or it's going to manage you. No other options, right? It's not another one that you can kind of just quietly deal with. So when we're looking at some of these tools, right? So looking at ADHD, which starts young. So again, when I am talking to somebody and they say, because in the substance use world, everybody looks like they have ADHD, right? It can just be part of post-acute withdrawal. So everybody looks like it. And so people are like, oh, they all have ADHD. And I'm like, pause. Have you asked about what they were like when they were little? Because it will show up when they were in elementary school. You will have noticed it when they were in kindergarten. Have you asked the family, did they have a hard time completing tasks? So before the substance use entered their lives, what were they trying to solve for? That's the important piece. Like that's how I get a differential diagnosis. Because when I'm doing treatment, it's also what I'm going to need to treat when they go into their recovery, because whatever the substance helped them manage, when we remove the substance, those behaviors are going to increase. So that's a critical component for us to be able to make sure that we are understanding when and why these behaviors started, so we know what we need to continue to work on. So the assessment tools include, so these are just some of the different assessment tools that you can utilize, right? Once upon a time, you had to be a psychiatrist to use those. A lot more providers and licensed clinicians are using these today. So again, it's a great start. I still strongly advocate from having somebody that is trained in assessments, providing those assessments. If you're working with children, most of the school systems have that within their own school districts to be able to provide the assessments. And it should include multiple places. So a true assessment on somebody having access or having ADHD would mean that you're getting self-reports. So the individual talks about their experiences. You typically get collateral information from like parents or caregivers. And then if they're in school, you would get it from schools. If they're an adult, then you want to have care. You're going to want to have collateral information, which might be family members, and then self-reports. That allows for us to see, is it chronic? Is it episodic? Because episodic would mean it's not ADHD. And then again, knowledge is power to me. So the more that you know, the more you can manage. So here are the goals overall for treatment of ADHD. So you want to improve awareness of cognitive impacts of ADHD. So normalizing it, this is what it is, right? I had a lot of teenagers that, this was years ago, that they would be like, I don't think I have ADHD. And I'm like, all right, so do we need a session to like grieve it? Like, what do we need to do with this? Because you do. So if you're not wanting it, we can have a conversation about that. If you don't want me to acknowledge it, like we can have a conversation about that, but you have it. So I'm going to talk to you about how it is impacting your life. And then we're going to talk about ways that you can improve it. And again, getting family involved, because I need family to support the same skills that we're providing the individual, whether that's a spouse, whether that's a parent, right? Whoever that is. You're going to increase the coping skills. So those are those emotion regulation skills, right? So when I had said earlier, I standardized all of our curriculum because everybody is going to be doing this. We're going to address the emotion regulation because that is going to be more impactful to somebody's recovery than almost anything else. creating healthy and balanced relationships. And so that becomes incredibly important. You want a spouse to understand ADHD so that they stop taking things personal, right? Again, as another example, my daughter, to this date, she is a very successful 29-year-old, right? In her career, she is very successful. She is a coach. To date, every time she comes to our house, she leaves every single cabinet door open. I know exactly what she ate in my house and which utensil she used, right? If we don't understand that, we can embarrass her. And so is it a big deal? No. Do we make light of it at this point? Yes. But that relationship isn't impacted as a result of a behavior that we're like, it's not that big of a deal. Right. But that's so important. So goals should be about the relationship as well. And as I had said earlier, one of the biggest impacts on an individual is work and relationships. So those are so critical in the way that we support somebody, no matter where they are within our care system. If they have ADHD, so I had plenty of adolescents that had ADHD, they didn't need talk therapy. I didn't need to process people's feelings. I didn't need to talk about their feelings at all because they just needed the executive functioning. I would talk about the feelings if they felt depressed as a result of the ADHD, but the skills are the skills. I didn't need to process some of that stuff. I might with a family, right? If they were feeling frustrated for that young man or that little boy that went through his attic, they had so much anger to him that we did process, right? Because he felt his parents pull away from him because somebody told him he had reactive attachment disorder. Totally different soapbox for me, right? But otherwise, there's been plenty of children with ADHD that came to me. I don't process a single feeling. They hardly want to listen to me anyway, right? So we just literally skill it, skills. Here's the identified behaviors. These are the things we need to practice. We're going to see if it worked. The beauty is that it works when it works. It's quick. Treatment planning. So are we missing the boat? How many of us are putting ADHD on our treatment plan? And so this is a question for you to take with you when you move on in your careers and where you are. Are you asking the right questions? Have you seen the behaviors? I tell my team all the time, I don't need a relapse prevention plan if this person's impulsivity and them cursing out staff is going to get them discharged. So how about we put that on the treatment plan? And then we talk about a relapse prevention plan as we get closer, because right now, while they're in treatment with us, we are their relapse prevention plan. So I don't need that. That's not my biggest area. Whatever's going to get in their way of being able to continue their journey of recovery, that's the most critical thing that we need to talk about. So is it on their treatment plan at all? Most of the time it's not. Some research suggesting, and this is what I had said earlier, if you address the impulsivity, you actually mitigate some of the risks of substance use. If you don't address the impulsivity, that can be what gets them in trouble. So I can't tell you how many times I hear somebody saying, like, they just wanted to use, I guess, right? They're still doing the same things. They're not ready for their recovery. And I'm like, that actually just sounded impulsive. Like, he left treatment because we gave him chicken nuggets and he wanted pizza. Like, that's not because he wanted to use, that's impulsive, right? So that's a shift in the way that we understand it and the way that we are talking to somebody with that. How many of us are saying the words impulsivity related to their ADHD versus like, you're just an impulsive person, this is your substance use? If they have ADHD, they're impulsive, period. The substance use isn't the impulsivity. They already had it. And then in couple counseling, that's another big piece, right? So if you're in the private practice world. So treatment planning, I can send this. If we're looking at goals and what that would look like, somebody had said, so what would it even look like, right? So I'm now identifying personal triggers. So it might be that I'm not going to work. It could be that I don't get up on time, right? So I have a young person that I'm working with. She's late to everything. That's what her treatment plan is. We are literally putting together skills to be able to get her to get up, to be able to get to her on time, because the time management is a struggle because she can't get herself up in the morning because she procrastinates. So that's what I'm addressing, right? So those are the goals and the objectives, and then the interventions. What are we doing that's going to help, right? Providing ADHD education on emotion regulation and impact of impulsivity on substance use. I need them to, at a basic minimum, I need them to understand the impulsivity and your lack of emotion regulation is your risk. So we need to make sure that we've got some skills in place that you can do these, right? So we have a recovery skills plan. So you're seeing that. I'm going to put that on there, that you're completing this with regularity, that we have identified. So if they don't complete it, I am now providing them opportunities to develop skills to get it completed. I'm not angry at it, but I'm also not like, well, I guess they're just never going to do it. No, they can do it, but they need help to be able to get there. Therapy doesn't help and does. So therapy doesn't change neurological basis or presentation of symptoms. So here's where we're going to start getting into therapy versus medications. And again, keeping in mind that this is a spectrum disorder, right? So some people can very successfully engage in behavioral tools that they have learned, and other people are going to need medication. But keep this in mind. All of those things that I just talked about the impact on their brain, the lower levels of dopamine, the lower levels of norepinephrine, the lower levels of serotonin, right? The lower levels of GABA. All of those things are neurological. Therapy is not going to fix that, right? So when we look at how does the person see themselves, including what is ADHD versus what it isn't, right? So these are some of the therapeutic approaches, how they approach their challenges. So do they have ADHD paralysis, or are they able to motivate themselves through a challenge, right? So where does their brain respond, right? Do they use the adrenaline to their advantage, or do they overwhelm themselves and shut down, right? How severe are the comorbidities? Because if they have severe depression, quote unquote, and ADHD, those two things will make it a little bit slower to be able to manage, right? Because now they've got these negative thoughts racing through their head that are impacting their ability to feel like that they can accomplish things. And how do they manage their lifestyle factors? So are they working? What's their relationships like? What's the home environment like? These are all critical pieces. And in those sessions, setting realistic expectations, right? So we are not asking somebody with ADHD to no longer have ADHD. I don't care if my daughter closes these drawers anymore, because there's other things that are a bigger priority to me. So I'm setting realistic expectations. I just don't care, right? Like there's other things that matter more for us as a family, right? Reduce the frequency of the behavior. So if they are interfering, then we want to reduce them. Are we going to get rid of all of them? Maybe not. Will they be late every once in a while? Probably, but we're going to reduce it. So setting those expectations reduces their ability to feel like they're still failing, which is what we want them to feel, right? You are not failing. This is where we are trying to move, right? So reducing the severity of the consequences, that's relational, that is through substance use, that is through work, right? Improving the confidence in the mastery of utilizing the skills and being able to kind of keep themselves regulating, building tricks. Tricks are fantastic for those with ADHD. Little hacks on organization, right? Little hacks on time management. Tricks are great for them. They very responsive. We all do, right? Just some individuals are able to utilize them more. So here are some of the clinical interventions. So evidence-based practices that have been shown to be effective for ADHD. And again, this is why you're not seeing a ton of like the process driven, right? I don't have Carl Rogers up there. No offense to Carl Rogers. Terrific, right? But ADHD, you're going to see progress with DBT. You're going to see progress with CBT, because they're going to focus in on some of the emotion regulations, manage that system, mindfulness. Do not ask somebody to become internally active in mindfulness for somebody with high ADHD, because otherwise you're going to frustrate the hell out of them. You try to get somebody with ADHD to get quiet in their minds and it's racing. And so you're going to see early aspects of frustration, but they can still learn the concepts of mindfulness. It can be active mindfulness in the beginning. You can start working towards getting quiet mindfulness eventually, right? But don't start there, because otherwise you're going to be really frustrating for them. And then the CBT can address kind of those automatic negative thoughts, right? So like that might be where you start processing some of these other things. I'm never going to do this. I'm always a failure. I always let people down. That we can address, right? That doesn't interfere with their ability to be successful. Time management, improved executive functionings, all of these things critical, right? The use of rewards are particularly helpful for children because they increase dopamine. So I wouldn't be using it. So be strategic about it, right? So what is the behavior that you're okay with? But if you incentivize that, it can be something exciting. It can be you get movie night, right? All of these things, but make sure it's short-lived. It can't be a week on, a week out, right? That's not really helpful for a child with ADHD because they can't sustain themselves that long. So changing it, family counseling and education, and then wellness. So overall, so I'm going to go over some of these areas pretty quickly. So natural remedies. So here's some of the nutrients that they have linked. So there's enough research today to say these do impact the brain, right? So omegas-3s, iron, zinc, magnesium, vitamin D, right? And then here are some other things. So when people are like, is medication the only thing? No, there's plenty of things that people can do that can naturally improve their ability to manage some of their ADHD. But again, keep in mind, this is a spectrum disorder. So there is not one-stop shopping or one size fits all. So if we're looking at like exercise, right, it's going to increase norepinephrine and dopamine. There's research to say that when somebody exercises regularly, it does mirror the effects of if they actually took their stimulants, because it does produce so much norepinephrine and dopamine. So that is worth the exercise, right? So getting in, proving that in serotonin, those are a direct correlation. So exercise is foundational, so critically helpful for somebody with ADHD. Mindfulness, again, strengthens the prefrontal cortex, which can help with the attention, decision making, right? The emotion regulation. So that's how mindfulness can help in supporting a person through some of that. If we are looking at like good sleep hygiene, that's where melatonin can come in, but it can regulate your neurotransmitters. So when we sleep, we regulate neurotransmitters within our brain, right? So poor sleep can worsen dopamine and the imbalance, right? So then it exacerbates ADHD symptoms. So these are things that you want to be able to talk about. These are things that you want to make sure that your patient or the person that you're working with is focusing in on and is attentive to it. And then these are, again, just roles in ADHD. If they take the supplements, have the conversation about what they can do. But there's no magic cure, right? There's an ADHD diet. So I'm going to start moving a little bit quicker so I can get to that medication, which I know people want to hear about. If we're looking at the ADHD diet, there is research to show that diet can improve, right? So we had some of the supplements that have been linked to improvement of ADHD, right? There's studies that show that there is lower levels of those omega-3s. So then there's natural foods that you can start to increase. So omega-rich foods can help with focus. The iron-rich foods can help for dopamine, right? Zinc for focus. So these things, this is why I'm a big fan of making sure that if I'm asking somebody to do something, that they understand why. I don't want to just say, take zinc, and they're like, okay. But if they don't know why, then they're not going to realize, like, listen, if you stop taking the zinc, maybe it's going to impact your focus. So pay attention to it. So make sure you're connecting those things together for somebody. And then we have medications for ADHD. So when we start to talk about medications, there are 3 different classes. So you have the stimulants that work by increasing dopamine and norepinephrine, right? These are executive functionings. These are not for trauma. You have the short acting, right, that have the immediate release. So the Ritalins, the Focalins, the Adderalls, right? Those have a higher abuse potential. Just saying that, right? You have then the short acting subs or stimulants, which are extended releases. So you can look at that, the long acting. And so those are going to be more of like your Concertas, your Focalins, XRs. So when people are looking at the difference, because it goes into your systems differently. So stimulants are the most commonly prescribed medication for ADHD. As I said, they increase dopamine and norepinephrine. And the medication, based on what's going on for that individual, can be short acting or long acting, right? And some people have both, right? So some people have like the Adderall in the day and then they have it again in the afternoon. The non-stimulants work by increasing norepinephrine. So if stimulants are not a good fit for you, then you have a couple of these options. So Strattera and Tuniv, right? These are a different option by increasing it and helping with focus and attention. An additional non-stimulant that has been found effective is an antidepressant, which can increase or especially for those that have depression, right, as well, but it has been shown to be effective for somebody with just ADHD, that the antidepressant medication can help those reduce some of the impulsivity, some of the aggressive behaviors, and increase their attention span. So because it helps to increase serotonin. That's what an SSRI does, right? So those are some of the medications There is enough research that shows that when people take their appropriately prescribed medication, it reduces their risks of a substance use disorder. So all of that controversial, like they're going to abuse their substances if we prescribe them medication, there is continued research, thousands upon thousands of research that show when appropriately prescribed in conjunction with behavioral interventions, it actually reduces their risk for substance use. So when we look at it, it just tunes down the volume of the person for the ADHD, right? Converting intentions into reliable actions. So that's basically what the medication does. It converts intentions into reliable actions. That's more reliably helping the executive functioning. For somebody that has significant ADHD, you just trying to do behavioral skills, they can't learn them. So sometimes the medication is needed. So again, I will equate that to a little bit of like the diabetes. Some people need insulin and some people just manage their diet because they're pre-diabetic, right? And so I'm not judging how somebody needs to be successful in their life, right? But I'm being honest about it. We're talking about it. If some people are worried about where they are, where risks are, if you've got family hit, make sure you're having the appropriate conversations, but don't just not do something because of your fear. And so that stimulant and addiction risk, will they become addicted? Again, consistent findings is that when the most risk person is an untreated person for ADHD, that is the highest risk. Somebody that is not treated for ADHD is the highest risk for substance use. Somebody that is appropriately treated for ADHD, even with a stimulant, is a lower risk for developing a substance use disorder. So having said all that, ADHD is awesome, right? So here's all the strengths. Here's what happens with treatment. ADHD is a superpower to me. I know some people don't like that terminology, but I actually think that it is. There's amazing things that can be done, but you got to manage it. And so with treatment, you have resiliency, you're fun, you are impulsive, you can make things exciting, you are brilliant, you are able to accomplish tasks that most people can't, but you got to pay attention to it, right? So highlight your strengths, know what they are, utilize them to your best advantage, and then make sure that your patients know the same, and then identify how they can support them. So this is your last one. I'm going to go through some of those questions that were in there and see if I can answer some of them. Do you recommend any books on ADHD for teens and adults? Yes. So I will put that, it was in my slides. I'll put that, it was in the last one, but I'll send that to Callie and she can make sure that we send that out. There's some really great books. What's the clinical distinction between ADHD paralysis and demand avoidance? I'm not sure I know the clinical demand avoidance, so I don't want to speak to that. That is not a phrase that I am around as much. If you have ADHD, but also the addict gene, do you manage this? Can you take Vyvanse? So I'm going to be careful with saying like the addiction gene. I think that you've got personalities. I think there's predispositions. And so I wouldn't give somebody Vyvanse unless I knew that they had ADHD, right? So, but I think that if you have a personality, that's why you oftentimes see like they channel it to something else. I think it's worth looking at that. So I never tell somebody that they have an addiction gene. I say you have predispositions, right? Family history or some of these other things, but we just have to channel it differently, right? You're going to be good at something. Let's just decide which one you want to be good at. So if it's substance use or something else, let's just be more targeted. I think that's most of those questions. What assessment do you recommend for females? Any of the assessments that, if you don't like, I mean, Connor's a big one. If you don't like Vanderbilt, then I would play around it. There's a couple of them that I listed in there. Again, sometimes it's just preference. So I'm not going to eliminate the hyperactivity because I do think that it's more present even in women than people think it is. Are you available for consultations? I mean, I'm certainly happy to help. I will say that. With the books, do you have some good tools and tricks? There are good books that have good tools and tricks. Just to clarify. Yes, zinc and omega were the supplements. Board games for younger children. Yes, the board games for any person with ADHD are short. Monopoly is not their friend. So we never owned a game of Monopoly, but we sure had a lot of quick games that were easy to turn over for both my husband and my daughter. So board games that are great are quick ones, not the long ones. Nobody wants to play a long game of a board game.
A few
So with all
people
that, thank you.
a few people did ask Trish about autism and ADHD and the correlation, the morbidity there.
So there is a high correlation. So they have that. I don't know if it is a causal, which I don't believe, right? So there is a correlation. I don't know the science behind how those two things, I don't know if it's that autism, there's a higher correlation for those with autism that have ADHD. I don't think it's the reverse. I don't think if you have ADHD, you have a higher causality of autism, but I do think that that's probably the opposite. But we do see it, but they are two distinct things. So sometimes people can get them confused and think they're the same. But autism is a learning disability, ADHD is not.
Okay. I think those are all the major things. Again, we will link any resources that she mentions, books and that kind of thing. Hopefully we will all see you guys back in June for our next webinar. If you need CEs, you will be getting an email shortly after this ends. The recording, slides, all of that will be uploaded next week. So I hope you all have a great, wonderful weekend. Trish, thank you as always. We'll see you in July again.
In
So,
July.
all
Thanks,
right.
everybody.
Thank
Have
you
a
all. Have
wonderful
a
week.
good, yeah, have a good weekend.